Hello, everybody. Thank you so much for joining. If you've just been signing on, it's great to have you. My name is Lauren Rumble, and I'm a senior associate with the Prevention Collaborative. And I'm just delighted that you all could join us so early and on time. What a great, enthusiastic group. I'm so excited to be here, and it's lovely to see that you're excited too. So it's actually quite a thrilling feeling watching the number of participants go up. It's my first webinar, so excuse my hasty enthusiasm for new technology. Okay, so one of our most important objectives as the Prevention Collaborative is to share practice knowledge amongst our members. And our audience today is largely comprised of exactly that, practitioners who have been knee-deep in programs, either designing them, running them, evaluating them, or helping to adapt and replicate them elsewhere. And I think we also have a healthy mix of policy advocates, funders, researchers, and activists online. Our hope is that webinars like these can be one of many global conversations about our experiences creating and adapting programs to reduce and prevent violence in the home, the single main focus of the Prevention Collaborative and many of us in our daily work. So why the focus today on parenting programs? We're particularly keen to know more about programs that work on the intersections between violence against women and violence against children back. Intimate partner violence, we know, is the most common form of violence against women, and harsh physical punishment and neglect by caregivers and parents are the most common forms of violence against children. Yet, a startling few number of programs actually are designed to holistically address these intersections and multiple forms of violence in the home. Parenting programs have been shown to show initial promise in doing exactly that, and we want to know more. So let me then dive straight in and introduce our panelists. Up first is Leanne, a developmental psychologist and professor of psychology at the Ateneo de Manila University in the Philippines, and she'll be talking about MAPA, a parenting program to address child maltreatment in the Philippines. Next, we'll go to Lindsay and Khadija. Lindsay is an associate professor at Washington University's Brown School, and she has over a decade of experience leading applied research in multiple continents on the protection and well-being of women and children in situations of extreme adversity. Khadija is a doctoral student at the Department of Population, Family and Reproductive Health at Johns Hopkins University with a primary research interest in prevention and response to violence. Both Khadija and Lindsay will be speaking today about Compass, a parenting program for adolescent girls in the DRC and also in a couple of other locations. And I think we have some members from IRC also joining us. Finally, Anjali will do the third presentation, and she's working as a senior research officer providing strategic leadership, research expertise, and technical vision under the Passages Project and on the Learning Collaborative to Advance Normative Change. She'll be talking to us today about the Real Fathers program in Uganda. So without much further ado, let me turn over to Leanne. Looking forward to you. I'll be clicking, by the way, so you might just hear our panelists asking me to click the slide. So if I get it wrong, apologies. Over.
Hi, good evening, everyone. Evening here in the Philippines. It's 10 p.m. And it's my first webinar, so I hope I'm coherent enough to go through the next 8 minutes of my presentation. So thank you for the introduction, Lauren. As she had mentioned, I am a professor of psychology here in the Philippines, and I will be discussing our initiative of the last couple of years to develop and test a program to prevent child maltreatment. And this is what we call the Masayang Pamilya program, which translates to Happy Family. And I also want to acknowledge all the collaborators in this project, in particular my co-investigators from University of Oxford, who are Jamie Lackman and Frances Gardner, and Kathy Ward from the University of Cape Town, and Judy Hutchings from Bangor University, and several other partners in the Philippines, without whose support this project would not have been possible. So just a bit of background on really what is the impetus for the MAPA program. We had conducted a national baseline survey on violence against children in 2016. And there it was really confirmed that there is a high prevalence of violence inflicted on Filipino children. Practically 80% of girls and boys reported having experienced some form of violence in their childhood. And a large majority would be inflicted by family members, particularly physical violence. So it makes sense to us to really focus on families as the focal point of interventions, because corporal punishment happens to be a very normative practice here in the Philippines. So the MAPA program was culturally adapted from a South African program, which we called Sinuvuyo Caring Families. And both the Philippine program and the South African program are part of an initiative of WHO and UNICEF called Parenting for Lifelong Health. And the objective of Parenting for Lifelong Health is to really develop a suite of parenting programs specially designed for low resource contexts. Next slide, please. So what are the objectives of the MAPA program? As I've mentioned, primarily it is really to reduce the risk of child maltreatment and to strengthen the caregiver-child relationship. In fact, you'll see in a while that the majority of program content is in fact all about strengthening that bond between caregiver and child. And also, of course, for caregivers to learn and practice effective and nonviolent skills to manage negative child behavior, and also to enhance caregiver and child well-being. So the program, as you can see over here, our model is a house. We call this the happy home or the home of support. And you will see that the walls, we consider the foundation of the happy home, and that foundation is the positive relationship between the parent and the child. And you will see here the different components of this foundational first 6 sessions, in fact, are all about spending one-on-one time with your child, identifying and talking about feelings, and using praise and rewards for positive behaviors. And then only then do we, in fact, tackle the roof, which would focus more on setting household rules and routines, setting consequences for going against these household rules and routines, and other nonviolent discipline strategies like ignore and redirect, and solving problems in the family. So this is administered in parent groups, about a maximum of 15 parents in one group and 2 trained facilitators. The entire program, as we had tested it a year ago, was 12 sessions. It also includes pre-program home visits. The facilitator visits the homes of the parent participants to set some very specific parent goals for the parent and child. We also use texting in between sessions to remind and encourage parents to practice. And the delivery of the program is very much collaborative. We emphasize that parents are experts in their own way. And so there's a lot of discussion and brainstorming of good practices, and facilitators model the behaviors that they want to see in the parents. And there's a lot of practicing of skills in the sessions and in the homes. So what worked? We were fortunate to be able to test this program. We ran a small-scale randomized control trial. And a key feature of this RCT is that we had been able to test it within the National Conditional Cash Transfer Program in a city in Manila. And the outcomes, as you could see on the slide, are very positive compared to a control group who received services as usual in this conditional cash transfer program. We saw less child maltreatment for MAPA participants, less dysfunctional parenting, less intense child behavior problems, more daily positive parenting, and more parental self-efficacy. What worked with respect to program delivery, these are from qualitative interviews and FGDs with the parents. They really liked that it was delivered in small parent groups because they felt supported when they were with other parents. We used illustrated stories or comics in demonstrating core lessons in the program, and they really appreciated that. Our parents are not highly educated, and they like the visual imagery that came with the core lessons. They like the messaging and phone calls from facilitators, and they also they noted the respectful, attentive, and capable facilitators. That was very motivating and served to make them more engaged in the program. Other good features would be, as I mentioned, the integration of the program in an existing service delivery system. So we see a huge potential in terms of scale up for the program through this conditional cash transfer system. There was very strong multi-sectoral collaboration between academics and service providers, government and non-government agencies. And we underwent a very careful process of cultural adaptation while maintaining fidelity to core evidence-based components. So we think that was also a really good practice. What needs to improve or other future work, we did not see program effects on parenting stress, parental mental health, or intimate partner violence. So these are some secondary outcomes that we were also hoping to see and test as correlates or mediators of child maltreatment. We did see a negative association between intimate partner violence at baseline and attendance, meaning those mothers who had reported higher rates of intimate partner violence tended to attend less sessions. And this is something that we need to unpack further because we can only hypothesize why this is so. Could it be a case of the partner at home, perhaps practicing some form of control or coercion so that the mother would be less inclined to attend a parenting program? We are not sure. There was also a negative association between parenting stress and attendance. So parents who reported higher stress related to child rearing actually were less inclined also to attend our program. So these are risk factors for child maltreatment, and it's unfortunate that they were associated with lower attendance. So that's something that we really need to attend to in future
Leanne,
program
I'll
delivery.
just give you another minute here. Thank you.
Okay. Then let's go to the last slide, I guess. There you go. So just as a whole, what worked, I thought, what were opportunities and good practices is that this program came at a time when at a national level and also at a city level, there was a lot of emphasis on violence prevention. The Sustainable Development Goals had come out, the Inspire strategies to prevent violence had come out. And so there was just a general air of acceptance and buy-in that we really need to reinforce some more in our current socio-political context. Elections are coming up in the Philippines, and child protection is not always a priority among our politicians. So we need to strengthen this buy-in for these violence prevention programs. We thought it was really good that there was integration of scientific evidence and practice. In a low-income country like the Philippines, we don't often have access to what's cutting edge or what's evidence-based. So partnership with international collaborators and scientists supported the development of this knowledge and helped to bridge the gaps. And finally, we really learned that we need to engage more with communities, parent leaders, community leaders. Our program would not have been successful without people on the ground really supporting us throughout. So I think that's it. The last slide would be some more information. There is the website of Parenting for Lifelong Health. There is a paper that we had recently published that I could provide for people who are interested. Thank you.
Thank you so much, Leanne, for that rich presentation, and we're looking most forward to addressing some of the questions that have already started to pop up in the chat box. We will have another 2 presentations and plenty of time for questions at the end, rest assured. So let's leap straight into the next one with Lindsay and Khadija. Over to you.
Hi, everyone. As Lauren said, I'm a doctoral student at Johns Hopkins University School of Public Health, and I'm co-presenting today with Dr. Lindsay Stark, who's an associate professor at the Brown School of Social Work at Washington University. We're going to present a bit about the COMPASS program today, which stands for Creating Opportunities Through Mentorship, Parental Involvement, and Social Support. We conducted COMPASS in the Democratic Republic of the Congo, and we'll be sharing some findings from the impact evaluation today. And we also just wanted to note that while we're both in different institutions now, this work was actually conducted at Columbia University, and we wanted to thank the Prevention Collaborative for giving us this opportunity to share the findings from the project, which is very dear to both of our hearts. So in short, the program was a partnership between the International Rescue Committee and the CPC Learning Network at Columbia to build the evidence base on interventions to prevent violence against adolescent girls. The IRC has a great resource called Girl Shine, which provides more details about the program. And we've included the link at the end of the presentation, and I'm just going to give you a brief overview here. Our colleague Mehreen Jaswal from the IRC is also listening in, and she'll be able to chat a bit more about the program itself during the Q&A. Can we go back one slide? Perfect. So just in short about the program, the IRC drew from evidence-based programming in stable lower and middle income countries to identify 4 pillars that together may help empower and prevent violence against adolescent girls in humanitarian contexts. And a visual depiction of these different pillars are in the photo on the left. And I'm just going to quickly walk you through what those 4 pillars were. So in the top left corner, COMPASS sought to build girls' life skills through about a 10-month curriculum, which was 32 sessions, held in safe spaces that are only accessible to women and girls, which were delivered by young female mentors and IRC staff. The curriculum focused on topics like safety, social and emotional skills, health and hygiene, solidarity among girls, and girls' visions for the future. On the top right, the program also included trainings to build the capacity of service providers such as teachers, healthcare workers, and other case managers to improve programming that's specific and friendly to adolescent girls. On the lower left-hand corner, which is the main component that we're going to be talking about today, the community engagement component of the project targeted caregivers of adolescent girls to improve their skills and communication with their daughters. And the point of this was to help recognize their needs and to also engage caregivers and helping keep adolescent girls safe. This was about 13 sessions, which more or less was once a month with caregivers of girls who were involved in the life skills program. Girls were asked to choose their own caregivers, and the majority of caregivers they chose were women, and those women were largely their own mothers. And the last pillar focuses on the international humanitarian community and improving our field's knowledge of adolescent girl needs and programming. And this pillar forms the basis of how we hope to use the evidence that's generated from the multi-country study for which these findings are a part to influence and impact donors, policymakers, and practitioners. All right, next slide. So the rationale for the impact evaluation was that while there's been much recent learning on parenting interventions in lower and middle income countries, most of these focus on younger children, and we know a lot less about the impacts of parenting during adolescence. We don't have much evidence for the unique contributions that parenting interventions can contribute to preventing violence against adolescent girls. And so with that in mind, the main purpose of the evaluation was to understand the incremental effectiveness of the parenting curriculum in addition to the core COMPASS programming on improving girls' safety and well-being. So we conducted the program and the evaluation in 14 communities in South Kivu using a 2-arm waitlisted randomized control trial. Our colleagues at the IRC placed girls into program groups based on factors like age and language, and then we randomized those groups to treatment and control groups. Since we were examining incremental effectiveness as a caregiver component of the program, all girls in both the treatment and control groups received the intervention in the DRC at the same time. It was the caregivers that were in the treatment arm that were invited to the discussion groups during the first cycle of programming, and then caregivers in the control arm were waitlisted and invited to participate in discussion groups after we completed the evaluation. So in this way, during that first cycle of programming, all girls completed the program, but only half of the caregivers participated in the parenting discussion sessions. This allowed us to compare outcomes of girls whose parents participated to girls whose parents had not yet participated in the caregiver sessions. In total, we had 869 girls and 764 caregivers participate in the study. We're not going to discuss this in detail here, but just wanted to briefly mention that we have a paper on the methods used to ask questions to girls, such as CAPI and ACASI, which stands for Computer-Assisted Personal Interview, and Audio Computer-Assisted Self-Interview. And so if you'd like to learn a bit more about those, we have those methods available. We also did not ask sensitive questions about violence to 10 to 12-year-old girls for ethical reasons. All right, over to you, Lindsay.
Thanks so much, Khadija. Next slide, Lauren. Oh no, you're on the right slide. The primary outcomes of interest that we set out to measure looked at girls' experiences of violence, but there were also a secondary set of outcomes, and those are the ones we're primarily focused on today. And those outcomes looked at whether we saw any changes for caregivers who are attending the monthly sessions in terms of attitudes towards gender and equitable norms, attitudes towards physical discipline of children, and parental behaviors and feelings towards their children using the PARC scale, which measures parental acceptance, rejection, and warmth. Next slide. We found that caregivers who participated in the program ended up reporting lower scores on the overall PARC scale and also on one of the subscales that measured parental warmth and affection. That may sound bad, but it's a little counterintuitive. Low scores are actually a good thing. So what that means is that caregivers in the treatment arm exhibited parenting styles characterized by greater warmth and affection and overall lower levels of rejection than those in the waitlist control arm. So that's the good news. Next slide. However, our findings also demonstrated that adding the caregiver component to the adolescent life skills programming did not result in reduced sexual, physical, or emotional violence against girls. It is worth noting that we saw a general decrease in violence against girls across groups, both groups from baseline to endline. But given the design of the evaluation, we cannot conclude that the decrease was due to the caregiver component of the intervention. Additionally, among caregivers, we did not find reduced support for harsh discipline or improvements in gender equitable attitudes among caregivers who participated in the discussion groups compared to those who did not. And our qualitative research provides some indication and I think illustration of these really deeply ingrained norms. So I have two quotes here. One says, if a man sees you exposing your body and poorly dressed, how could he not jump on this opportunity? Wouldn't you be responsible for your own rape? Wouldn't you have caused your own demise? Men don't know how to control themselves if they see intimate parts of a woman. And the second quote from a caregiver says, in the event that a wife was hit by her husband, I would first tell her to try to understand why her husband did it, because a husband wouldn't just hit his wife if she hadn't done anything wrong. In this case, she would have to do everything that is in her power to change her own behavior. So ultimately, we were still seeing significant signs that girls and women would both be considered responsible for sexual and physical violence. Next slide. So overall, in terms of some of the major lessons we learned, clearly tackling gendered norms and social norms likely requires intensive and repeated interventions at all levels of the community. And since the program included 13 monthly sessions for caregivers as compared to the 32 sessions for girls, it's likely that the dosage was insufficient to change these very deeply entrenched gender norms. Additionally, targeting one caregiver per household may be insufficient to address an environment that condones violence and may ignore complex power dynamics within the household that facilitates violence against adolescent girls. Additionally, as Khadija mentioned, we found that girls frequently chose their female caregiver or mother to participate in the program with them, yet we know that male caregivers and intimate partners were the most frequent perpetrators of violence. And that leads to our next lesson learned about the need to engage men and boys, which is something I know that the IRC has been thinking about in their current programming, and perhaps Maureen can add more when she chimes in later in the discussion. And finally, more evidence is certainly needed in humanitarian contexts, but also we learned some important lessons around when the evaluation may best happen. The RCT was implemented during the very first iteration of the COMPASS intervention. And so, of course, the IRC was also engaged in a very huge learning curve during that first iteration and made a number of changes to their own programming and how they implemented the program in later versions. And so in a way, it's a shame that we didn't have the opportunity to evaluate one of the later, more refined versions of what is now Girls Shine. So sincere thanks to the COMPASS teams, and especially to the girls and the caregivers who shared their stories with us. And as Khadija mentioned on our last slide, we have a link to the IRC report, as well as the open access published findings of the evaluation, and the CPC link where you can find a full list of our publications related to the COMPASS intervention. So I'll end there and look forward to any questions. Thanks so much.
Thank you so much, Lindsay and Khadija. And rest assured, everybody who's looking at these resources excitedly, we'll make these publicly available on our website, as well as a live recording of today's webinar, as we breathe through some very dense information that many of us will take home. I'm just going to turn now to our last presenter, Anjali, who will be talking about the Real Fathers program in Uganda. Over to you, Anjali.
Thank you. So I'm going to talk about the Real Fathers program in Uganda, but I'm really going to focus on the adaptation and scale that we did between 2016 and 2018. So next slide. So Real Fathers was developed through in the Institute for Reproductive Health, where I work, and Save the Children had an existing intervention with adolescent girls in northern Uganda. And in working with the communities there, we started to hear a lot about a desire for mentorship and guidance for young and new fathers to learn about how to be a good parent and how to be in relationship. And this really came out of a community that had experienced over 20 years of conflict and had lost a generation of uncles, fathers, elders in the community that traditionally provided this type of mentorship to young fathers. So we designed this program through extensive formative research, and we decided to focus on three main things. So the first was looking at fatherhood as an entryway to discussing and promoting gender equitable and positive masculinities. And we really wanted to take advantage of this life stage when people are going through a new experience, taking on new roles in their families and in their communities as well, and that they have a strong commitment to their children and to their families. And we thought that this was a great opportunity for interventions. Another thing that we were looking at was trying to reach young men before their relationship expectations, attitudes, and behaviors are set. So we focused on men between the ages of 16 to 25 who were new fathers, which meant that they had kids between the age of 1 and 3 years old. And it was a strategic decision when we were thinking about how to work on social norms and what opportunities might exist from a project that wanted to be a little lighter touch in the beginning, but could have impact. And so we focused on this stage when young men were starting to take on new norms in the community and experiment with them and decide how they wanted to be as a parent and as a partner. And then lastly, we were trying to look at this integrated violence pathway, so looking at violence in the household as well as violence against women and violence against children. So the objectives of the overall project are to prevent physical punishment of young children, so children aged 1 to 3, and to prevent physical and psychological intimate partner violence. And we sought to improve parenting attitudes and confidence in nonviolent discipline, as well as to foster acceptance of non-traditional gender roles in parenting. So next slide. So the Real Fathers components are shown here, and it's really a community-based mentorship program where young fathers are identified by the community themselves. It says that these people would benefit from such an intervention, and we brought them together in a forum where young fathers identified men in the community who they respected and would feel comfortable getting mentorship from. And then we had their intimate partners as well as community members validate that that was a good role model for their partner or for the man. So that was, we had a phase of selecting and training mentors, and then we had a series of home visits and group meetings over a 6-month period that were focused on parenting and relationships and visions for the family. And then we coupled that with a poster series, which debuted each month. So there were 6 themes that went throughout the program, and there was a poster that corresponded to each theme. And the poster was designed to reinforce messages that were given in the mentorship program, but also to build on what existed within the community as expectations and norms on positive parenting and family relationships. And then we concluded with a community celebration where men would stand up in front of their community and their partners would stand up, and they would talk about their experiences and their accomplishments and their commitments to go forward. And we thought this was an important part to kind of solidify what they were learning and that they wanted to continue to be a part of it. Next slide. So we started Real Fathers as a pilot project in northern Uganda, and we conducted a baseline, endline, and a 1-year post-intervention survey, and we found that the project was effective on all of the main objectives. So we decided to start looking at what would it mean to adapt this and to maintain fidelity to the intervention in a new setting. Could we take this model to a completely different place? And we were trying to understand both how do you scale it and can it be integrated into existing platforms so that we could, if we wanted to think about sustainability, that would help us think about integration. So between 2016 and 2018, we expanded the intervention in northern Uganda and linked it up with livelihood interventions that were taking place there. And then we went to a new area called Karamoja, which is also in Uganda, and it's an area that's quite different from northern Uganda. So it's traditionally nomadic. It has strong community structures similar to northern Uganda and a lot of advising between members. There's a lot more, people live in a very different way, and there was a lower literacy level in Karamoja, which made us really sit and think deeply about what does it mean to adapt the intervention. Next slide. So I'm going to start actually with the right side of this, but I'll just say briefly that we also did an evaluation of this study qualitatively and quantitatively, and we continue to find at endline and 1-year post-intervention that harsh physical punishment of young children was reduced by 25 to 50%, IPV was reduced by 25 to 50%, and we saw a 2 to 4-fold increase in confidence in nonviolent discipline. But I can go into more methods if people are interested later. So when we look at what we changed, we had to think about context and culture and language. So a lot of our posters and the messaging on the posters changed, and the key content on messages that might resonate with community members, we adjusted it to match what resonated more with the community. And we did this through establishing a local advisory board where we really consulted on all steps of the intervention and went through the training curriculum together to try and understand what would work in this setting and what they thought would not work. We also recognized that in this new setting, our mentors would be of lower literacy. And so we needed to simplify our training and our curriculum even more. So we really reduced content in the curriculum while trying to hold on to the main themes and core values of the project. And then we also initiated a co-mentor setup where all the illiterate or less literate mentors were linked with a literate mentor who could provide them guidance, help orient them to the protocol if they've forgotten anything. And then we reversed the session order. So in the pilot, we did the individual sessions first and then the group session so that they were they were closely linked with each other. But in this adaptation, we decided to do the group session first and the individual session after, because it gave our mentors an opportunity to observe other mentors practicing and to reinforce what they were doing before they went on a one-on-one situation with the person that they were mentoring. And then we also divided our training into two parts. So we had one at the beginning of the intervention and one midway through. And then we also introduced supportive supervision to really try and guide the mentors and do more follow-up and answer their questions so that if they weren't able to read anything within the manual, they were still getting all the resources they need. So coming to the left side of this slide, we started to think about also what does it mean to maintain fidelity to the intervention. And at the time we were doing this, people had been thinking about fidelity as really maintaining the same intervention, but making some cultural and language shifts. And we really started to think a little bit differently, and I think this is what we've heard other people on this presentation talk about. We started to think about what does it mean to maintain the core mechanisms of the program and the core values while adapting the intervention for the location. So when I say core mechanisms, I'm talking about how the program was designed to respond to men's needs and motivations, which is really positive focus, thinking about new skills and understanding for men, focusing on their family and themselves and their vision, and not so much on violence and harm and punishment. It also includes the role modeling, where respected mentors were guiding men through this process and other men participating were sharing their experiences. And it included the mentorship, the community engagement, and the public testimony through the celebration. And then when I'm talking about core values, it's really about mentorship staying as the core vehicle. So we really wanted a community-grounded mentorship model to guide men through the program. And we also wanted to maintain the focus on young fathers and toddler-age children as the key target group. And we kept community at the heart of the intervention throughout the process. We looked at gender transformative change as a center piece of the program and the curriculum, and focused on positive messaging. So I've talked a lot about the rest of this. So the beginning with the end in mind was really thinking about scale from the beginning, which was an advantage for us because we thought about keeping the intervention light while trying to be as effective as possible, and thinking about the mechanism strategically so that if the project proved to be effective and we wanted to adapt it, we weren't dealing with something that was so complicated that it was either too costly to move or way too complicated to move, or we wouldn't understand which of the mechanisms and values were the most important. Next slide. So
I'll give you another minute, Anjali.
Yeah, sure. Okay. In conclusion, so what we really learned was thoughtful adaptation is possible and needs time. I think we spent, when we brought the intervention to Karamoja, somewhere between 3 to 5 months adapting our materials and consulting with the community and testing things out, and really explicitly identifying what our values and mechanisms were for the program was very helpful because it helped us all have a common language, and it helped make sure as we adapted, we were still retaining these pieces. Thinking from scale from the beginning has been a very useful piece, and focusing on the positive messaging and norms. So I think our next steps as a project is when we did this evaluation, we did survey research with men. And so we asked men about their use of violence against women and their partner and against their children. So we are interested in doing a validation of this by talking to women, because we do know that they may report differently. We're also interested more in transferability to other settings, so outside of Uganda, and also thinking about humanitarian settings or other cultural locations where some of these same mentorship dynamics might exist in the community. And then we want to dig more deeply into what it means to be sustainable and scalable. Can we integrate this within existing platforms at a regional or a national level so that it's less dependent on an organization and is more part of an existing system? So that is it. I'm happy to answer any questions.
Thank you so much, Anjali, and sorry for the time pressure. We're definitely going to be reverting to you as colleagues ask many questions which have already started to pop up on our screen. The last picture is, of course, of my little boys, because like many of you, I too am a parent and have wished for more information in my own parenting journey. It's a deeply personal conversation when the programs become so close to the lives we live. So let me turn then to the attendees. We have a couple of questions already. For Anjali, some questions about how did you engage the fathers? What was the magic? Was there any tricks or strategies there? For example, the role models. For Lindsay and Khadija, did you conduct some formative baseline research before you started? What about third generation caregivers? And this is a question for all the panelists. And what was your theory of change in Compass? And for Leanne, if you could talk a little bit more about how you were expecting, and I think this is the fascinating part, you were expecting to see a change on intimate partner violence levels. You didn't, unfortunately, and thank you so much for being frank and honest with us about that. That's how we learn. What were you expecting? What intervention were you expecting to make that change? Before we go to all of you, while you're thinking about your answers, let me just ask our IRC colleagues if you would like to speak here to mention anything about the scale up of Compass and what you learned from this experience. Marine, I think you might be online, or Megan?
Yes, Marine here. Can you hear me?
Yes, very clearly. Great. Nice to hear you. Welcome.
Thank you very much. Thank you so much to all the presenters. I just wanted to take the opportunity to just give an update on where we are since the Compass findings were launched. We have recently worked on the Girl Shine program model and resource package that really has been shaped by the findings from Compass and also through IRC's other adolescent girl programming that we have. And as a result of this, we have the Girl Shine program model and resource package, which includes a life skills curriculum for adolescent girls, but we have since Compass really strengthened the GBV lens throughout the curriculum. But I would just like to talk a little bit more specifically about the caregiver curriculum in particular, as the findings really did bring up some of the limitations with the curriculum that we had been implementing. And as a result, we now have a new curriculum that really aims to address the broader issues of gender inequality within the family structure, but also how this impacts adolescent girls' experience of gender-based violence inside and outside of the home. And then the second point I just want to mention about that too is that the curriculum also now aims to address the power dynamics between female and male caregivers and adolescent girls, and really tries to acknowledge and give space to women to share their own experience of the limitations that they face within the family structure, while also ensuring the needs of adolescent girls remain at the center of the intervention. And one of the things that Lindsay highlighted was that through the Compass intervention, the girls were given the option to select a caregiver, and this was predominantly a female caregiver that was selected. As we have now separated this curriculum out, we are intentionally targeting male caregivers separately to female caregivers. So we're hoping through this improved approach, we will be able to engage more with male caregivers when it comes to gender-based violence that adolescent girls experience. And then just a couple of other things I just want to flag more broadly, just outside of Girl Shine. IRC is currently undergoing a process of adapting a program model that we have, which is called Engaging Men in Accountable Practices, which is a GBV prevention program, and we are adapting this, in the process of adapting this for Liberia to be piloted hopefully soon for adolescent boys. And then we also have another project called Safe at Home, which is really looking at the co-occurrence of IPV and child maltreatment, and draws upon IRC's parenting curricular approaches and also EMAP. So this is currently being piloted in DRC and Myanmar, and as we're still in the pilot stage, we don't have any research findings just yet to provide on that. But we really are trying to see how we can work more broadly with the community at large to address the issue of GBV for adolescent girls. And just to say that, you know, it's important to acknowledge that social norm and behavior change really is just one piece of the puzzle when it comes to addressing this systematic inequality and subordination of women and girls. And so we are trying as much as possible to address this at the various levels, both from the individual perspective and also from the community. Thank you.
Thank you so much, Marina. I think it's fantastic to hear about a program that's in more than one country. So congratulations to the IRC and for making all your resources a public good. I've really enjoyed the Safe Place to Shine report myself, and I recommend it to everybody. So back on the questions, let me turn to my esteemed panelists. And if I could just ask you to think about, I've heard a couple of people say to me over the last few months how hard it is to program for both women and child outcomes, and that different lenses and frameworks have to be used, and that parenting programs in themselves are really hard and really intensive and expensive. So if you could just think about that and see whether you agree or not as you're answering. Do I have any volunteers? Maybe I just pick Leanne. Would you like to respond to the questions on the MAPA curriculum and on the cash conditional transfers? Who delivers them?
Right, there were several questions about our conditional cash transfer program. So this is a national government program where very vulnerable families are given cash on a monthly basis, but they have to meet certain conditions. For example, they have to attend a monthly family development session on various topics like nutrition or gender sensitivity, even parenting. So in our trial, the control group actually went through those family development sessions because they were part of their the benefits that they receive, whereas the treatment group underwent MAPA, and MAPA was counted as their FDS session for those several months. And other conditions included having to ensure that your child is enrolled in school, and also making sure that they get their monthly vaccinations and regular checkups. So it's really a great opportunity to bring a program to scale because it is a national program. And we believe that perhaps that's, the best possible way to bring a program to scale is to integrate it in an existing delivery service. That said, at this point in our trial, the facilitators, and that was another question, the facilitators who delivered the program in our RCT were quite highly skilled. A number of them were psychologists, graduate students, some were even physicians and teachers. So we have yet to test the program using actual community service providers and paraprofessionals as facilitators. That would be our next step, that we would have to see how such an intensive parenting program might be delivered with good quality and good fidelity by actual people on the ground. Because again, that would speak to issues of scale. For this program to be sustainable, it has to be delivered by actual service providers and community people.
Did you want to come back on the IPV question? Was there any specific targeted intervention to address the intimate partner violence, or that's something you're thinking about for the next version? Over.
That really is an interesting question because it was never, in fact, an explicit objective of our program. We were banking more on the research literature, that talks about how caregivers who use harsh punishment and corporal punishment may have had experience of violence themselves, either as children or with their partners. And indeed, from our baseline data, about 40% of our sample in the RCT did report experiencing intimate partner violence in the previous month. That's 40%. But there was no content in our program that directly addressed intimate partner violence. we were thinking, though, that some of the skills we were teaching the caregivers in the program, for example, giving praise and managing your emotions. We taught them some very basic mindfulness skills to help manage their anger, problem solving, things like that. We were thinking that perhaps teaching caregivers these skills, which then they would practice at home with their children, might translate to other systemic changes in the family. Might they be applying the same skills to their partners? We thought that might be possible. And from our qualitative data, we did have reports about mothers saying, they found themselves praising their husbands for the first time in their married life. And that brought tears to their eyes because they never praised their partners before. So we were thinking more of indirect changes, more systemic family relationship changes. So, it would have been a really pleasant surprise to see actual outcomes pertaining to IPV, given that we did not have any direct content related to that. So maybe that's something that we would need to think about some more and strengthen in the future, if that is an outcome that we really want to make as a goal of the program.
Certainly, we would hope so. Thank you so much, Leanne, and thank you for being so honest and comprehensive with us in your answers. Let me turn now to you, Anjali, on the questions about engaging older mentors, the fathers themselves. Over.
Yeah, sure. So I'm going to start with engaging fathers. So we engaged fathers. I think we were lucky in that when we first started the program, we were implementing it in a community where they had expressed a desire for fathers to receive guidance and participate in some kind of parenting or partnership program. So we were really able to build on what the community had already identified as a need. And then the community themselves nominated young fathers to participate in the program. And so when we expanded it and adapted it, we maintained that same model where we consulted with local leadership and had them start to identify men to participate. And we sought the consent of their wife and the young father before trying to figure out who wanted to be enrolled. So it was partially their own interest and a community push to get people in. And then the men were involved in one-on-one mentoring with their mentor, as well as a group mentoring where groups of 4 mentors came together with about 20 young fathers to do mentorship. And then they also participated in the group session. And there were 2 couple sessions as well. So for a total of 12 sessions, 2 of those were couple sessions. So that was the way we engaged young fathers, and we really focused on the positive and really reinforcing it through community mechanisms such as displaying the posters so that men were seeing this message and understood that the community was also very supportive and invested in their own involvement in the project. As for working with elder mentors, there was a question about, how do we deal with like messages that could be more about right and wrong rather than transformation? So the mentors that were identified by the men themselves as people that they trusted and thought would give them a good advice. And then it was validated by their wives and other people in the community, which provided support that these might actually be good role models and not people that were practicing the harmful behaviors that we were trying to address. And then the mentors participated in the adaptation site. They participated in 2 5-day trainings, and in northern Uganda it was 1 5-day training. And that we took them through the curriculum itself. So they had some training on gender and some training on relationship dynamics and children, and then they went through all of the sessions that included skill building activities and homework and knowledge sharing and facilitation, so that by the end of it, we were really trying to give them enough skills to be able to stick to the curriculum and not create their own messages, although there obviously is room that people can say what they want to say. But through that, I think we really tried to stay focused on a group of men who were mentors that were already incentivized to provide mentorship because they had consented and the community had identified them. I think that answers the 2 questions. Did I miss one?
There's one more for you, but let's see how we do on time. Meanwhile, thank you so
Sure.
much for dealing with that so succinctly. We appreciate it. And I'm going to turn last but not least to Lindsay and Khadija, who had a bevy of questions. I think you've got them all, but just in case, a lot about how did you structure the group sessions? How did you do the male and female sessions separately or together? And what about third generation caregivers, as well as the theory of change? Over to you.
Great. I'll start, and Khadija and Maureen, I think, can both provide some additional insights. I actually wanted to start with the theory of change is a quick one. So, I would refer people to our protocol papers or endline papers or the report where the theory of change is explicitly stated with some visual diagrams as well. The question around sort of the formative work, baseline work around understanding the social norms and attitudes. We actually have a paper that Kate Falb was the lead author on in Child Abuse and Neglect that analyzed the baseline data, and is quite interesting. So, the findings from that analysis suggest that the female caregivers' own gender equitable attitudes for adults were associated with reduced odds of violence and less acceptance of intimate partner violence for their adolescent children. But interestingly, the parental attitudes and beliefs about gender equity for the girls themselves were not necessarily associated with the violence risks. So there were some interesting findings there, but ones that really do, again, support the idea and the notion of the importance of shifting and addressing gender attitudes and norms for the caregivers. Khadija and Maureen, I think I'll turn it over to you for, particularly Maureen, for the questions about the current forms of programming and how that looks with caregivers.
So currently in the updated Girlshine caregiver curriculum, the sessions for male and female caregivers are separated out. So we're no longer having them together as they were in Compass. And mainly this was because of issues that female caregivers in particular expressed about not being able to express freely when male caregivers were present, and also in some cases male caregivers dominating conversations.
Whoops, we just lost you, Marion. Hello? Well, I think we may have lost her, but we'll come back to you in a second if you can hear. I'll type in the question box. I think that we may have reached the end of our time, so let me just quickly check in with Khadija if you wanted to add anything here.
Sure, so I think maybe briefly checking in on
there you are. Hi, there you are, Mary. Okay, sorry, Khadija, hold on one second. Okay,
no,
great. Technology let us down for a sec, but you're back.
No, this is Khadija, sorry. I don't think Maureen is here, but I think maybe seeing if she can get back online, sort of talking quickly about the theory of change. The goal of the program was to help keep adolescent girls safer from violence, and so moving backwards from there, there was sort of balancing the need to provide leadership and empowerment opportunities to girls, and sort of focus on girls' skills development, and also addressing the environment around adolescent girls. And so the IRC sought to do that through engaging caregivers, for example, through thinking about services in ways that adolescent girls might be discouraged from seeking help or seeking assistance from people. And that sort of formed, I think, the core of the programs that we saw. I think, as Lindsay mentioned, one of the, I would say, surprising to me findings was around, how much intimate partner violence it was, and that recognition that girls in this young age group, which is ages 10 to 14, are starting to engage in those kinds of relationships. And so situating, these girls in different contexts, but considering that they are adolescent girls and that their worlds are starting to expand, right? It's not just caregivers they're engaging with or teachers, but there's a lot of things going on amongst peers. that we need to start thinking about and thinking about how to incorporate. I think that was one of the big takeaways I had. And it's something I'm excited to see how we can work on that, you know, as a field.
Thank you so much, Khadija. And that's the perfect place for us to just draw this really exciting conversation to a close. Our time is unfortunately up. But all these resources, as I said, will be available. We'll make sure they're sent both by email, as well as a link to our website and the live recording. And I've really enjoyed the questions. Thank you to our attendees for your thoughtful inputs and insights. A huge big thank you to our panelists. This is where technology is not quite the same as giving a rounding applause and some flowers to everybody who presented so beautifully and so concisely. It was a lot of material to get through. But I really like the hands-on approach, the fact that we had so many age groups, parenting programs for different age groups in different countries, in low and middle income countries. So thank you so much. It was a great, great session, and thank you for your attention. Have a lovely day, evening, and rest if you're in the Philippines, and see you at our next webinar.